Hey everyone, and welcome to The Explainer. Today, we're taking the headache out of GI pharmacology for your nursing exams. If you've ever felt totally overwhelmed staring at a massive list of gastrointestinal medications, trust me, you're not alone. We're going to take all those dense textbook facts and transform them into a high-yield, structured study guide that actually makes sense. So let's get ready to make these concepts stick for good. Here's our game plan for this top-down GI journey. First up, managing gastric acid. Second, controlling nausea and vomiting. Third, regulating bowel elimination. And we'll wrap the whole thing up with some challenging NCLEX practice questions to test what we've learned. All right, part 1, managing gastric acid. Let's look at antacids, H2 blockers, and proton pump inhibitors. So these three drug classes handle stomach acid in completely different ways. Think of them like different levels of defense. Antacids are basically basic compounds that just jump in and neutralize the existing acid that's already hanging out right there in the stomach. Then you have your H2 blockers, like ranitidine. They go a step further by actually blocking histamine receptors on the parietal cells, which tones down acid secretion. And finally, your heavy hitters, proton pump inhibitors, or PPIs, like omeprazole. These guys shut down acid production right at the source. Let's really zoom in on how PPIs work step by step, because this is a huge exam topic. They bind directly and irreversibly to the hydrogen-potassium ATPase pump, literally physically stopping the movement of hydrogen ions out of the parietal cell. The result? A total complete blockage of acid secretion for over 24 hours. Now here is an absolute must-know NCLEX insight. Because they lower stomach acid so effectively, long-term PPI use actually interferes with calcium absorption. And that means a significantly higher risk for osteoporosis and bone fractures down the line. Keep that in your back pocket. When it comes to antacids, you absolutely must remember these critical nursing interventions for your exams. First off, always give them with at least 240 milliliters of water, just to make sure they absorb properly. Crucially, you've got to space them 1 to 2 hours apart from any other medications. Why? Because antacids are notorious for blocking the absorption of other drugs. Oh, and remember the classic side effects? Magnesium will cause diarrhea, while aluminum and calcium are going to cause constipation. Quick pause. If you're finding this explainer helpful for your nursing exam prep, go ahead and hit that like button and subscribe to the Nurse Crush It channel. Seriously, your support is a huge help and lets us keep creating more content just like this to help you absolutely ace those exams. Moving right along to Section 2, controlling nausea and vomiting. Time to explore antiemetic medications. So antiemetics aren't just one thing. There are actually multiple classes, and they all work a bit differently. You've got serotonin blockers like ondansetron, which are heavily used for patients dealing with chemotherapy-induced nausea. Then there are prokinetics like metoclopramide, which basically jumpstart the gut and stimulate gastric emptying. We also have antidopaminergics, such as promethazine, and finally anticholinergics like scopolamine. Scopolamine actually blocks receptors in the vestibular nuclei, which is a fancy way of saying it's great for preventing motion sickness. Now, let's talk patient safety with antiemetics, because this is where you earn your nursing stripes. You have to constantly assess for signs of dehydration. We're looking for dry mucous membranes and those telltale longitudinal furrows on the tongue. You also need to be on high alert for severe adverse effects. For instance, metoclopramide can trigger extrapyramidal effects. And here's another massive NCLEX must-know. Ondansetron carries a serious risk for QT prolongation, which can lead to incredibly dangerous cardiac arrhythmias. Okay, continuing our top-down journey, Section 3, regulating bowel elimination. Let's talk lower GI meds. Basically, we've got two main lower GI drug classes sitting at total opposite ends of the spectrum. Laxatives are there to facilitate bowel movements and relieve constipation. On the flip side, antidiarrheals are meant to prevent or treat diarrhea by slowing down GI motility or binding to toxins. But no matter which way you're shifting the bowel, speeding it up or slowing it down, the golden rule remains exactly the same. You must carefully assess your patient's baseline fluid and electrolyte levels before doing anything. Let's hit a few high-yield laxatives. One huge fact you need to know is about lactulose. Yes, it's a hyperosmotic laxative, but it is uniquely prescribed to reduce toxic ammonia levels in patients suffering from hepatic encephalopathy. You've also got to know your bulk-forming agents, like psyllium, and stimulant laxatives, like senna. Quick tip for senna: always instruct your patients to avoid taking any other medications within 1 hour of taking it. When we're treating diarrhea with meds like loperamide, which is a synthetic opioid that decreases bowel motility, you always have to keep the bigger picture in mind. Fluid and electrolyte replacement is absolutely vital. That's why oral rehydrating solutions, or ORS, are always the recommended first-line therapy for the dehydration that comes with diarrhea. Also, a really quick heads up on adsorbents. They coat the GI tract and bind to bacteria, which is great. But definitely warn your patients that they can cause dark stools. You don't want them panicking over that.
All right, section 4, NCLEX practice and review. Let's see how much you've absorbed.
Here's our first clinical scenario. A patient with kidney failure wants to take an antacid. Which type of antacid is most likely to cause a toxic accumulation of electrolytes in this patient? Is it aluminum, magnesium, calcium, or both B and C? And the correct answer is magnesium-based antacids. Remember, severe kidney failure is a strict contraindication here because the kidneys just can't filter everything out, leading to a potential toxic accumulation of electrolytes. Specifically, magnesium preparations can cause incredibly dangerous magnesium toxicity in anyone with compromised renal status. Let's try a question about administering PPIs. A nurse is administering omeprazole. Which action is the most appropriate for this medication? Crushing it in applesauce, giving it whole before meals, giving it after meals, or chewing it thoroughly?
The right answer is giving it whole before meals. You literally cannot crush, open, or chew omeprazole because doing so completely destroys its intended mechanism and its absorption in the stomach. It's got to stay completely intact.
Moving right along, let's test your critical thinking on bowel elimination meds, specifically lactulose. A patient with hepatic encephalopathy is prescribed lactulose. What is the primary therapeutic goal of this medication for this specific condition? Relieve constipation, reduce ammonia absorption, replenish normal flora, or prevent fluid loss?
Did you catch it earlier? The correct answer is reducing ammonia absorption. Yes, lactulose is technically a laxative, but for a patient with hepatic encephalopathy, its main job is to pull toxic ammonia out of the system. This is a highly tested concept on nursing exams, so lock that one in. Okay, let's look at a challenging assessment question for antiemetics. Before giving the serotonin blocker ondansetron, a nurse notes longitudinal furrows on the patient's tongue. What does this finding most likely indicate? Extrapyramidal effects, alkalosis, dehydration, or acid rebound? The answer is dehydration. If you're giving ondansetron, chances are the patient has been vomiting. That means dehydration is a massive risk. Longitudinal furrows on the tongue, dry mucous membranes, and decreased turgor are your classic red flags for fluid volume depletion. Let's finish up with prioritized interventions. What is the most critical first-line therapy to administer for a pediatric patient experiencing severe dehydration from diarrhea? Is it loperamide, ORS, probiotics, or adsorbents?
The correct answer is ORS, or oral rehydrating solutions. Before you ever reach for drugs like loperamide or adsorbents, you have to prioritize fluid replacement, and that goes double for vulnerable pediatric patients. Keeping this whole top-down GI journey fresh in your mind, I want to leave you with one final thought. How will you adapt these complex pharmacological concepts to prioritize safety and solid patient assessment in your daily clinical practice? Keep crushing it, and we will see you in the next explainer.